What impact will the recently reported findings of the second-line study have on regimen selections in HIV patients experiencing virologic failure?
The second-line study was conducted mostly in resource-limited settings, and the main implication it has is for those settings, specifically places where people are universally started on NNRTI-based regimens and are followed often without a viral load monitoring, sometimes with viral load monitoring, and usually a second-line regimen after failure is designed without the benefit of resistance testing. And so in this study, they randomized patients to either receive lopinavir/ritonavir plus nucleosides, which is the standard approach used now, or lopinavir/ritonavir plus raltegravir. The advantage of that second regimen, the raltegravir plus lopinavir/ritonavir regimen, is that it doesn't contain any of the components or classes of drugs that was used in the first line regimen, and therefore the need for resistance testing is sort of unnecessary because of the fact that you're not using any drugs that you used to begin with. And the study found that both approaches worked quite well. Now, in our setting, we have resistance testing, and what's different about our world is, for one thing, people failing first-line therapy typically are failing because of non-adherence, because they had baseline genotype testing done, so they didn't fail because of unrecognized transmitted resistance, and so generally they're failing with resistance, and so or with non-adherence, and so dealing with the adherence is often the biggest issue. But our selection of the second regimen is really based on genotypic testing, which is not available in many parts of the world. But I think what the second-line study does for us is, for one thing, it provides further evidence that nucleoside-sparing regimens can be okay. And it's kind of amazing that we've had nucleosides now since the middle of the 1980s, and we have still not found regimens that are acceptable that don't contain nucleosides after all these years. This is a study where we've seen an example, lopinavir/ritonavir plus raltegravir, that appeared to work very well in patients who had no protease resistance and no integrase resistance. And so I think that it helps us for second line in the sense that if we have a patient failing ART with non-nuke resistance and some nuke resistance, that would be an appropriate choice. But it also may help us get toward the idea that there are nucleoside-sparing regimens that we can use first line. And they would typically include a protease inhibitor that was boosted plus either an integrase inhibitor or perhaps an NNRTI. And we still need more substantial data to support that concept, but it's something that becomes important when we have patients, for example, who are infected with nucleoside-resistant virus or patients who have contraindications to nucleosides. So for that reason, I think the second-line study has implications both for resource-limited settings as well as for us.